Hello, warm greetings. I am Dr. Amir Orbani, retinal surgeon, currently working at Saudi, north of Iran, and I'm very happy that this is the second episode of One Surgery, One Experience. I want to talk about tractional retinal detachment surgery in two parts. The first part belongs to patients that I've provided some explanations for them, and the second part is a brief talk to my retinal colleagues, and I hope that be beneficial for all of you. Thanks. Well, tractional retinal detachment is end stage of diabetic retinopathy. It is notable that most of the patients that we're facing in clinic evolve to this stage because of not referring to their physicians for a period of time, as much as metabolic status, including blood sugar, hypertension, hyperlipidemia, getting worse and poor control. This period of time will be decreased to even 6 months. But most of the cases that I saw are patients who did not visit their physicians for a period of 1 to 2 years. But what is happening during this period? In this period, retina experiences recurrent hemorrhages, and this hemorrhage acts as a scaffold for fibrous tissue proliferation from the retina into the vitreous, forming membranes. These membranes exerting vertical forces over the retina, finally leading to tractional retinal detachment. At the time that macula, the area responsible for central visual acuity, is involved, the surgeon may decide to perform a surgery and remove these membranes and release these vertical forces over the macula. It is very important to know that removing membranes and reconstructing the retina structure is not necessarily associated with improved visual acuity. So, my firm advice to my diabetic patients is that we should do everything to avoid this stage by periodic examinations and imagings, and also following their treatment plans, either intravitreal injection or retinal lasers. Well, the second part is a dialogue, a subspecialty dialogue with my retinal colleagues. Tractional retinal detachment is a wide spectrum of cases, including patients with small scatter epicenters to diffuse extensive broad-based TRD. And of course, the most important factor in choosing this strategy for vitrectomy of these patients is something that I call surgeon instrument factor. Of course, it is very important that how much experience the surgeon has and what was his or her previous outcomes from the surgery. Of course, it's very important that where are you doing the vitrectomy? Are you performing with intraoperative OCT, or you are performing vitrectomy in an operating room without appropriate visual system? This makes a great difference. By the way, I want to focus on tractional retinal detachment in extensive and broad-based types. And of course, I want to focus on one important question. Is it necessary to remove all membranes or not? There is no simple answer yes or no to this question. Some surgeons advocate for removing all membranes even with multiple iatrogenic breaks. On the other side, some surgeons are more conservative and they advise for clearing macular membranes and avoiding unnecessary manipulation at peripheral retina. Of course, both of these strategies have their cons and pros. But what I've seen in literature, in surgeries of vitreoretinal experts, and in my experience, I believe that there is a significant difference between these two conditions. When you have no break, or when you have at least one break, one or two or more, maybe is not very different. Note that I'm talking about extensive broad-based TRD. Until you have no break during the surgery, your concentration is limited to 1. Clearing macula, 2. Removing vertical tractions from epicenters, and 3. Reducing forces from peripheral vitreous to the epicenters. But at the time that you meet the first break, you have to remove all the membranes in the break area to reassure persistent retinal attachment during the time. And of course, removing membrane in these tough cases with atrophic retina may lead to more and more breaks. I agree that you will finally manage the case and finish the vitrectomy, but consider the significant increase in time of the surgery. Consider the significant more manipulation, more tamponade applanation, and more areas of broken retina. Does it really translate to more or even equal? That I seriously doubt. Even equal outcome comparing to less manipulation, less removal of membrane, but without break? It is very hard to answer this question, as designing appropriate clinical trials is hard. However, considering all data and literature, it seems that nasal and inferior TRDs are gentle pathologies, and their progression rate is considerably slower comparing to other traction sites. I believe that we focused on 1. Clearing macular membranes, 2. Removing vertical tractions from epicenters, and 3. Releasing forces from the peripheral retina. But do not try to manipulate and delineate extensive adhesions in nasal and peripheral retina if you feel that your maneuvers will likely result into retinal breaks. Remember that sometimes less is more. It means that less manipulation would result in more favorable outcomes. Well, I don't want to talk about surgical techniques in this episode. However, I'm interested to talk about these techniques including M-block, delamination and segmentation, divide and conquer, and of course my personalized technique in another episode later. Thanks for watching, guys. I'm waiting for your valuable comments and feedback. Have a nice day. Best wishes.